Good morning. Still, it's before 12. Right. So we are going to have a case-based discussion. It's about which drug amidst a plethora of diabetic treatment. So I'm going to talk about incretin therapies. I'm going to start with a case. So our patient is a 49-year-old male with type 2 diabetes, well controlled on metformin 2.5 grams daily for the last 6 years, but his recent HbA1c was found to be 8.5. He has multiple other cardiovascular risk factors. He was obese, high blood pressure was there, and lipid levels were elevated. So the question is, what is going to be your second therapy after metformin? Is it glycoside? Is it sitagliptin, empagliflozin, liraglutide, or insulin glargine? So I hope most of you will think I'll choose liraglutide because I'm speaking on this topic, but I'm sure a significant number will also think about starting empagliflozin here, which is a SGLT2 inhibitor. So we'll go to the lecture and let's see whether we can pick up few points where we would favor liraglutide or empagliflozin in this man. So in my next 18 minutes or so, I'm going to focus on 4 main areas: the differences and similarities in the mechanism of action of different incretin-based therapies, the clinical effects of incretins on glucose control, weight, and cardiovascular risk factors, some prescribing considerations, and finally, a little bit about what's new in the pipeline for these therapies. We all know how important incretins are in the management of glycemia, especially after meals. There are 2 natural incretin hormones in the body, but they have a very short duration of action because of this DPP4 enzyme which breaks them down. These enzymes seem to play a very significant role in the body. They have effects on major organs. In pancreas, they increase insulin secretion, reduce glucagon, and some effect, at least in animal models, to preserve the beta cell. And they improve insulin sensitivity, acting on liver. They have heart protection effects, and they also act on the brain to reduce appetite and promote satiety, and some form of neuroprotection has also been suggested. We know that these effects are much lower in diabetic patients, but it seems like at least the GLP-1 effect is partially preserved, which we have explored in therapy. So at the moment, we have 2 therapies with GLP-1. One is GLP-1 receptor agonists, which have modified structure and they are resistant to DPP4 degradation, and they achieve supraphysiological levels of GLP-1, whereas DPP4 inhibitors essentially inhibit that enzyme which degrades body's own incretins, thereby prolonging its effect. So at the moment, the GLP-1 market is crowded. We have multiple agents, the extended-4-based therapies, exenatide and lixisenatide, as well as more homologous one-to-human GLP-1, the liraglutide and the semaglutide, and 2 other molecules, dulaglutide and albiglutide. Also, they have prolonged action because of the modification of structure with these agents. So at the moment, we have short-acting ones, which we use twice daily, and we have long-acting ones, which we use once weekly. So most of these GLP-1 receptor agonists, we need to start them at lower dose and titrate to prevent these side effects of nausea and vomiting, except for the exenatide long-acting, we start with the fixed dose. And when you consider DPP4 inhibitors, we have multiple agents there, most of them excreted via kidneys, except for linagliptin, where you can use without any dose reduction in renal failure patients. And it seems like out of these multiple effects, that if you achieve this supraphysiological level, that you are going to get these things like appetite reduction and reduction in gastric emptying. So those effects seems to be the ones where the GLP-1 agonists lead to weight loss. Whereas if you take DPP4 inhibitors, they mainly act on the pancreas, on the insulin and glucagon. They are good glucose-lowering agents, but they lack this weight-losing effect, and they are essentially weight-neutral drugs. So let's look at some clinical effects these agents have shown. So this graph shows the clinical effects of glucose lowering different agents have shown. This is not a head-to-head comparison, but it seems like they have a very good glucose lowering potential up to from 0.8 to 1.5 HbA1c lowering effect. And it seems like liraglutide and dulaglutide have a slightly higher effect than the others. And we also got data now from this newer agent semaglutide, which seems like having even more potent effect than most of the available GLP-1 receptor agonists in glucose lowering. And it has done better than the basal insulins. Now, one question comes is, though these things come up in clinical trials, do they actually work in real-world data? So this is from British Clinical Diabetologists nationwide liraglutide audit, and that shows that you get pretty much the same effect which has been shown in these clinical trials. And the higher the HbA1c you start with, you are going to get more HbA1c lowering with these agents. And they have also looked at how these liraglutide would work in patients are on different glucose lowering agents. So one thing they have noted is if you start them on patients who are on insulin and patients who have long duration of diabetes, you are going to get lesser effect. So you can explain it because these patients most of the time has a low beta cell mass, and we know that these drugs act on the pancreas. So if you have low beta cell mass, the expected effect is going to be lower. But however, the clinical effects you get with adding liraglutide to insulin still is clinically significant. So it means that you can use it, but the message is if you start them early, you are going to get more robust effect with these agents. And as I explained earlier, GLP-1 cause weight loss in majority of the patients, and depending on the potency and the longer duration of action, you might get higher weight loss with certain agents. DPP-4 inhibitors are essentially weight neutral drugs. So this slide summarizes the different study findings for each agent. And as you can see, liraglutide seems to be more potent when losing weight compared with others. And then again, we have the data from the semaglutide, and it seems that that effect is even more potent than the liraglutide effect. So liraglutide, you know, that is registered for as an anti-obesity medicine. So I'm sure soon the semaglutide will follow. So one other thing we need to consider is that if we consider another agent like insulin, sulfonylurea, or even pioglitazone, the patients will going to gain weight. So what we are speaking is these agents lower the weight, and the absolute benefit the patients are going to get going to be much higher than if you put them on a weight-inducing drug. Not only on weight, they have also shown to have effects on other cardiovascular parameters like blood pressure. So both DPP-4 inhibitors and incretin, the GLP-1 receptor agonists, have shown to lower blood pressure, systolic blood pressure more than diastolic. And you may have heard earlier that they possibly could reduce the albuminuria, and they can reduce proteinuria, and there's possibly they can reduce glomerular injury by that mechanism as well. And there seems to be some favorable effect on lipid lowering as well with both of these therapies by reducing LDL and triglycerides, and with DPP-4 you get small increase in HDL. So the question is, do these beneficial effects in glucose lowering, weight, blood pressure, and lipids, do they translate into a cardiovascular benefit in the patients? Right, so now we have almost the data from almost all the major cardiovascular trials done in these groups. Recently, the results of Carolina study on linagliptin and the Rewind study on dulaglutide were presented in ADA. So now we know that DPP-4 inhibitors, essentially they are cardiovascular neutral drugs. They don't cause any excess mortality. And when you come to GLP-1 receptor agonists, we know that some of these agents like liraglutide, semaglutide, as well as the dulaglutide, they have clearly shown that they reduce cardiovascular mortality. So the exenatide long-acting one reduced cardiovascular mortality, but it was not statistically significant. So there's a question going on whether this is a class effect or not, but if you look at these trials, the way they have conducted, there are a lot of heterogeneity, so it's difficult to comment, but it seems like this is a class effect. So going into the guideline committees have certainly considered these new trials. Earlier you knew that they said after metformin you can choose any of these drugs, but the newer guidelines recommend after metformin, if the patients have elevated cardiovascular risk, you either start with GLP-1 receptor agonist or SGLT2/1 inhibitor. If they have kidney disease, maybe SGLT1 inhibitors would be better, but if they are contraindicated, still GLP-1 receptor agonist would be a better choice. Right, so coming into some prescribing considerations with these agents. So if you start incretin therapies early in the course of management, after the failure of metformin, you are going to get better or robust response with these agents. And for starting them on top of insulin or sulfonylurea, there may be a dose reduction would be necessary. Otherwise, patients could go into hypoglycemia if you start GLP-1 with them. And we have these short-acting GLP-1 receptor agonists, things like exenatide, and then we have these long-acting once-weekly preparations. So the short-acting ones have a major effect on postprandial blood sugar, whereas the long-acting ones have a major effect on the fasting blood sugar. So depending on which situation you want to control, again, that could be considered before selecting therapy. If you start a long-acting one, the once-weekly preparation, it will take some time to achieve steady-state concentrations, so you can't expect results in few weeks. It will take about 4 or 5 weeks to get the maximum effect. In renal failure, you have to be cautious because agents like exenatide and lixisenatide are renally excreted, so beyond certain levels, especially below 30, they are not indicated. The liraglutide seems safe. With the LEADER trial, we know that they seem safe in renal impairment, and maybe other ones like dulaglutide still could be used in renal impairment, but we are awaiting more data on this. There are a few contraindications. If there's personal or family history of MEN2 or medullary thyroid cancers, these agents are contraindicated because in trials, especially in animal rodent trials, there was C-cell hyperplasia, which was not shown in humans, but still, if there is a family history like this, these agents are contraindicated. And if the patients have gastroparesis, again, you have to be cautious because these agents cause a lot of nausea and vomiting, and therefore that can aggravate that disease. What about the pancreatic safety? There was a huge concern about these agents causing pancreatitis and pancreatic cancer, but with the current evidence, the FDA and European Medicines Agency, they have informed that there seems to be no causal association between incretin therapies and pancreatitis. And the recent RCTs, especially the cardiovascular outcome trials, as well as some meta-analysis, did not show any increased pancreatitis risk. However, it is listed in the manufacturer's leaflet, so you have to be cautious when using these agents. So how are you going to advise the patients? So some of these weekly ones comes with a complex mechanism. You have to prepare them before injection. So these things have to be told to the patient, and they might need a special injection device or needles to inject these newer, more long-acting GLP-1 receptor agonist. And nausea and vomiting being the most commonest side effect, we can give some simple advice like if they feel full, stop eating, because we know that these side effects will reduce with time and they will lessen the nausea and vomiting. Injection site nodule has been noted with these exenatide weekly ones because they employ a special delivery technique with some microspheres with exenatide binding into polymers. So those things will dissociate after injection in few days' time. And these are weight-losing drugs, may be the most potent out of all the diabetic therapies we have at the moment, but you have to be realistic of what they can do. It may be about 3 to 4 kilograms, maybe a little bit more with semaglutide. But if you combine with other measures, I'm sure you can achieve better results with these agents. And if the patients get unrelenting abdominal pain, it may be pancreatitis, still you have to be mindful about that. Right, so going into the last section, so what does the future hold for these promising kind of therapies? GLP-1 receptor agonists, you know that undoubtedly they are going to play a major role in future. There are newer medications, the oral medicines have been developed and they are on trial. More long-acting preparations are also on trials, which will reduce the number of injections. And then cost is expected to come down. At the moment, it's a major limiting factor is the cost. With some patents will expire, and we know that they have very good cardiovascular safety and probably the renal benefits as well. What about DPP-4 inhibitors? They are likely to play a major role in future as well because their prices are coming down and they have a very remarkable safety profile as well. So just to show you what's in the pipeline, the oral semaglutide has been developed. Clinical trials show a lot of promising effect, HbA1c lowering as well as weight loss, quite similar to the injectable preparation. So we are waiting the more results from these ones. And then they are developing these GIP and GLP dual blockers as well. Their results in phase 2 seems to be very impressive as well, much more glucose lowering and weight loss, but at the same time, they have noted with higher dose, you are getting more side effects. And we are talking about newer delivery techniques. These ultra-long-acting GLP-1 receptor agonists, which contain exenatide, as in a form of osmotic pump. You have to just implant it subcutaneously. We deliver the drug for about 6 months and eliminate the need of injections. They have shown good results, and we are waiting more data with them. Right, so coming into the conclusions, so one size will not fit all. Same here, if you're choosing these therapies, you have to select the patients who will benefit most and certain side effects or certain things like contraindications are there for therapy, so you have to select them properly. If you start them early, they are going to get more robust glucose lowering effects, so that is definitely worth considering rather than start thinking about them at a very late stage. These agents at the moment considered as the most robust agent in losing weight, and their cardiovascular and renal risk profile make them even more lucrative. At the moment, cost remains more significant barrier for these therapies, but with the patents expiring with some of the earlier agent, it is expected to prices to come down, and they are definitely going to be a better option in future. And we know that now that the newer long-acting preparations and more powerful oral preparations are being developed. So I'm sure in future we have to keep an eye. They are definitely going to change the landscape of diabetes treatment in future. Right, just to finish, so I'm sure some of you may know that by this time next year, you are going to have the Summer Olympics in Tokyo, and it is expected that in the men's 100 meters, there is going to be fierce battle for the crown, and it's no different for the oral anti-diabetic drugs. So this time, by next year, I'm sure there's also going to be fierce competition between these oral anti-diabetic drugs. So who will win the race? Well, we'll have to wait and see. Thank you very much.